Hello everyone, my name is Dr. Tanzeel Rahman and this is first of many videos on gastroenterology and hepatology. So first off, I will discuss hepatitis B and its diagnosis, its management as per European Association guidelines, American Association guidelines and Asian Pacific Association guidelines. I will also dig deep into special conditions like hepatitis B and cirrhosis. Hepatitis B and in patients without cirrhosis, we have hepatitis B E antigen positivity or negativity, immunosuppressed patients, pregnant women, and hepatocellular carcinoma along with hepatitis C and HIV co-infection and extrahepatic manifestation of hepatitis B. First off, hepatitis B is a DNA virus and it causes inflammation of the liver that we know as hepatitis. The modes of transmission of hepatitis B are either horizontal or vertical transmission. Horizontal transmission means that patient receives some IV transfusion or intramuscular injection, or patient has contact with the body fluids of someone affected, and patient either has sexual activity that leads to the transmission of the pathogen. Moreover, there is also vertical transmission in which the virus is transmitted from mother to fetus transplacentally. So, it is very important that we know the burden of this disease, and I would not be amiss to say that it is the bread and butter of many hepatologists, and if you know the right management of hepatitis B, it would help you in the longer run. 296 million people are living in this world with chronic hepatitis B virus. That is a very huge figure. And out of those, 8 lakh deaths per year are from the complications of hepatitis B like cirrhosis, hepatocellular carcinoma, and acute decompensation or fulminant hepatic failure. Next, we will delve into the diagnosis and natural history of this virus. Why is it so important to learn about its natural history? It is because most of the management decisions that we make regarding the management of this virus are based on the serology, the serum ALT levels, hepatitis B virus DNA PCR. A liver biopsy can or cannot be considered depending upon the patient. We have to monitor in the long run for cirrhosis and hepatocellular carcinoma. So in short, we have to deal with biochemical factors regarding the hepatitis B. We have to deal with virological factors, and also we have to deal with histological factors and complications. So these are the complications. If we cover the patient on these 4 terms, then we certainly have mastered hepatitis B. First off, it is very crucial that we understand the difference between acute hepatitis B and chronic hepatitis B, because all the management guidelines are based on this differentiation. In acute hepatitis B, patient has an early phase in which patient contracts the infection, following by a window phase and later a recovery phase that we will discuss step by step. If the patient does not have complete recovery, patient will fall into either chronic hepatitis B. 5% of the patients go into chronic hepatitis B, or patient might have acute liver failure or fulminant hepatitis failure. In chronic hepatitis B, we have 4 phases. Patient have immune tolerant phase, patient have immune active phase, our patient can or cannot go into inactive carrier state, or an occult hepatitis B virus infection. All of these will be discussed in serology. Next, when a hepatitis B virus pathogen attacks a liver cell, it attaches to it through hepatitis B surface antigen and hepatitis B surface antigen receptor on liver cells. So what it does is it sends its DNA into the cell, which in turn will enter the nucleus, where it will replicate as well as transcribe. The transcribe is formed after transcription, and transcription is done for messenger RNA. So it will have extra DNA as well as messenger RNA. This messenger RNA will be responsible for using the cellular machinery like ribosomes to form more proteins which are responsible and needed for many functions. This transcribed messenger RNA will be responsible for formation of proteins which will be needed for the virus. So what it will do is that you will find multiple viruses inside the liver cells which are now ready to attack other cells. When body sees this whole course, what it will do is that now it knows that there is an intracellular or intrahepatocyte pathogen. What it will do is it will mount a T cell response as well as a B cell response. B cell response, as we previously discussed, is basically E antigen, core antigen and surface antigen antibodies which form across the course of infection, whereas the T cell response is different. It is cytotoxic CD8 positive T cell response. So what CD8 positive T cell does to the liver cell is, because the pathogen is residing inside the cell, the CD8 positive T cell will have to kill the liver cell as well as the hepatitis B virus DNA virions. So what will happen is, when this hepatocyte is damaged, it will spill into the blood its own enzymes which are ALTs. These are also known as transaminases. Also, hepatitis B virus DNA will also spill into the blood. So we can see the necrosis and post necrosis changes which are called necro-inflammatory changes by doing ALT levels and hepatitis B virus DNA levels. Herein comes a very important point, that if we want to see the necroinflammation that is occurring at a specific stage of the infection, and we have discordance between ALT levels and hepatitis B virus DNA levels. That is, if increased ALT and increased hepatitis B virus DNA shows that there is necroinflammation and that is secondary to hepatitis B virus, what will it show when there is increase in ALT but decrease in hepatitis B virus DNA? So these are contrary changes, and these depict that there is some other cause, that is other than hepatitis B virus, which is responsible for hepatitis. So herein, to find that other cause of hepatitis, we need a liver biopsy. Also, when there is low ALT and there is high HBV DNA, we again need a biopsy because we have to consider that raised ALT is not the only marker of necroinflammatory changes, and sometimes we have to look into the tissue itself to find those histopathological changes. And the second thing is that when we have raised hepatitis B virus DNA levels, they in long term are responsible for complications like hepatocellular carcinoma and hidden occult cirrhosis. So, up until now, we have discussed how the disease progresses and how do we monitor the course of hepatitis B infection. So let's summarize the discussion that we have had. We monitor hepatitis B biochemically through ALT levels and serology. We monitor it by viral markers like hepatitis B virus DNA PCR. And we also monitor the virus when we have a discordance between ALT and HBV DNA and we are unable to make decision. So we go for a liver biopsy, which is a histological marker. In serology, we discussed that we have three antigens, which is core antigen, hepatitis B E antigen, and hepatitis B surface antigen, and the three antibodies are made against them. We will use these antibodies, these antigens, these ALT levels, this hepatitis B virus DNA PCR and liver biopsy in conjunction to make all the necessary management decisions. We also screened for hepatitis B complications, which include cirrhosis and hepatocellular carcinoma, and this is true for chronic hepatitis B virus, which persists for longer periods of time. We monitor cirrhosis by elastography, which is ultrasound guided, or magnetic resonance MR angiography. We monitor it through indirect chemical markers. We also monitor for hepatocellular carcinoma by doing triphasic CT scan of the liver and also chemical markers like serum alpha fetoprotein and PIVKA2. Next, a very important point that should be made is the immune status of a patient is directly proportional to the necroinflammatory response. In other words, when we see the immune status of the patient, it is directly proportional to the ALT levels and indirectly proportional to the hepatitis B virus DNA PCR levels. To make you understand better, if patient is immunocompetent, patient will have high necroinflammatory response, so the ALT levels in this patient would be very high, whereas the competent immune system will not let the virus replicate, so the HBV DNA levels in the blood would be low. But opposite is true for immunocompromised patient. In that patient's ALT will be low and patient's HBV DNA level will be very high. The most common immunocompromised patients that we know are pregnancy, one of the very important conditions, hepatitis B associated with HIV virus, and infants and older adults. It is very important to understand that patients who are pregnant, are immunocompromised, or infants, or older adults will have very high hepatitis B virus DNA levels. These patients who are immunocompromised and have very high HBV DNA levels would need antiviral drugs